So my name is Fiadhnait O'Keeffe. I'm a senior lecturer in UCC and a clinical psychologist and clinical neuropsychologist. I'm really delighted to be here today for the AIMS RN Symposium and chairing the psychosocial research in MS panel. I'm doing the first talk in this panel as well. Really, I'm supposed to give a broad overview of some of what we might refer to as invisible symptoms, or the psychosocial aspects that we know can really impact people with MS in their quality of life and in their relationships, in every aspect of their life in lots of ways. What I'm going to start with is giving an overview of some of the clinical research that myself and my colleagues have been involved in over the last number of years. And I would say a lot of the research projects that have developed within this research framework have very much come from working clinically with people with MS. So you'll see a familiar theme of some of the questions that we have sought to answer in some ways as best we can, reflecting in terms of what has been really important priorities clinically and for research for people with MS. So when we're talking about psychosocial impact of MS, to start things off, it's not one thing. There's so many different facets to it. I suppose we're talking about the emotional impact of living with a chronic illness like MS and what that's like, adjusting to a new diagnosis, but also some of the more mental health aspects that we know people with MS can experience in greater proportions than people who don't have MS. And Rebecca's talk will touch on some of the mental health and stigma aspects shortly. Also the cognitive challenges, so I'll speak a little bit to that now in this talk, and it'll be picked up in some of the later talks this afternoon with my colleagues in Vincent's and UCD. And fatigue, such a common feature for lots of people living with MS. One of the research questions that we'll talk about is how so many of all these features are interconnected. And as I was pulling these slides together, connections and interconnections seem to be a common theme, and I'll explain as I'm going through the talk about why that is. And really, I suppose, what we're thinking about is supporting people living with MS in their quality of life. We want people to live well and really think about ways of understanding what gets in the way of living well and how to support people to manage some of the difficulties that they can experience. And also very much in terms of, nobody's an individual. We all live in a social world. How some of the MS symptoms can impact from a social perspective, so social cognition, and that'll be picked up in some of the later talks this afternoon, but also relationships, and I'll touch on some of those aspects later. And then on the flip side of that, we know from general well-being and lifestyle that the social connections and peer support and connecting with others can be really helpful for people living with MS. Things like sleep, how sleep impacts people's quality of life, whether you're living with MS or not, is hugely impactful. And I suppose one of the things that when we're thinking about the psychosocial aspects of MS, looking at one piece of any of this in isolation isn't going to really explain the kind of more holistic picture. Sometimes when we're looking at it from a research angle, things can feel quite deficit focused, or we're looking at problems and we're looking at the deficits and we're trying to tease that apart. And, for everybody who is either living with MS or working with people with MS from a clinical perspective or a research perspective, we know that there's huge strengths and resilience in managing to live well with a chronic health condition like MS. And so really picking up that, making sure that things don't go in that balance of just deficit focused. Picking up the resilience, coping, how people manage well, how there's post-traumatic growth, how there's so many different aspects that can support people in that holistic viewpoint. But everybody in this room, whatever your background, whatever whether you're someone living with MS or whether you're a researcher, will know that all these factors are interconnected. And I think that very much is a theme of the research that we've been doing. When we think about cognitive changes, we know that approximately 2/3 of people with MS may experience some cognitive changes. Generally, they're along the milder spectrum, and that's in comparison to things like dementia or acquired brain injuries. It's the cognitive changes experienced by most people with MS are along the milder range, but they're very heterogeneous in nature, and even if they're along the milder range, can really impact everyday functioning in different ways. And I like this quote because it flags up that often the cognitive difficulties are not appreciated. So they're one of those invisible symptoms that can be missed by clinicians, but also mustn't be assumed. And it's that balance between, yes, we need to make sure that we're addressing cognitive difficulties if they exist, but also not assuming that they're there. Don't know why that jumped backwards. So when we're thinking about the neuropsychological profile in MS, some of the typically affected cognitive domains, people will be well aware that one of the core symptoms from way back in Charcot's 1877 days is the information processing speed as a core symptom. And a recent review showed that 36% of people with MS did show some impairment on a very brief cognitive screen called the SDMT, Symbol Digit Modality Test. So this very much is something that comes through in so many different research studies. Also attention, concentration, and particularly thinking about divided attention or sustaining attention for a long period of time. Executive functioning is just a big, large umbrella term for so many different aspects, things like working memory, so being able to hold things in mind and manipulate information and do things with it and in the short term. Dual tasking, that divided attention bit, problem solving, the cognitive flexibility, verbal fluency and social cognition, which my Vincent's and UCD colleagues will talk about later, and verbal and visuospatial memory, but very much in that encoding and immediate recall stage, not in what lots of people think when we talk about memory difficulties, that it's that more difficulties with delayed recall. That's less typically experienced for people with MS. But one of the things, again, think about the more strengths-based model, not just deficits-focused, is flagging up that actually there's a lot of domains that are less likely to be impacted in MS. And that's general intellectual functioning, longer-term memory, and that language comprehension bit. And that is just, it's important to hold those bits together as well. We know the cognitive deficits are more pronounced with progressive MS and longer disease duration, a higher lesion load, location of lesions, and brain atrophy. The other aspect around cognition that we're interested in MS in particular is the longitudinal features, and that's what happens over time for some of these cognitive domains. And that will be picked up in some of the later talks as well. Cognitive fatigue in MS is really integrally, whatever that word is, linked with cognition in MS. So we know that fatigue is the most common symptom reported by people with MS, and 70 to 90%, but actually other studies show 98% of people, when asked, will say, yes, I experience significant fatigue difficulties with MS. It's also considered one of the worst or most disabling symptoms of MS, surpassing pain, and it really impacts quality of life for people with MS. And when we're thinking about fatigue, cognitive fatigue in particular with MS, we're thinking about it in terms of the primary difficulties with fatigue, so that's how any changes in the central nervous system might impact fatigue and functioning, but also secondary fatigue, and that's as an indirect result in relation to pain, sleep disturbance, some mood issues, bladder issues, and some of the other related issues that might be impacting fatigue. So one of the things that we were interested in looking at is how much of a role does cognitive fatigue and self-reported fatigue play in information processing. So a couple of years ago, David Bellew, a master's student, looked at this with 192 people with MS, looking specifically at self-reported fatigue and a cognitive screen called the BICAMS, which I'm sure many people here have heard of. So that's 3 short cognitive tests, the SDMT, the California Verbal Learning Task, and the Brief Visuospatial Memory Task. Some of the key findings here were that higher fatigue, in terms of that self-reported questionnaire, was associated with lower performance on information processing tasks and verbal learning and visual learning. And after controlling for processing speed, the correlation was weakened, but it was fatigue was particularly predictive of verbal learning difficulties. And so that's important, because that certainly would be what we might see clinically, or we might hear from the people that we're working with. But it's really important to think about, okay, well then is there support or interventions that we can put in place to support people who might be experiencing a lot of fatigue, so fatigue management aspects, or that cognitive rehabilitation programs consider the impact of fatigue also. So when we're thinking about how all these things are interconnected and related, so this might be something that we might hear when we're working with people with MS. So they might say, I can't concentrate, my mind goes blank, I actually don't know what to do, what if I can't do my work? And the feelings might be, you might feel alarmed if you're caught off guard, you might be sad, or you might feel frustrated or irritable. And then the behaviours that might follow from that there are many things. You might be more hypervigilant. You might be more paying attention to when you lose track of what you're saying in the middle of a talk, in the middle of a conference, or you might avoid work tasks, or you might avoid social situations. But then that has its own knock-on effect in terms of physiologically, what might impact your sleep, your heart might race, the motivation, if it's more sadness or low mood, might impact your physiology also. How that impacts things like avoiding social situations. You might feel embarrassed when it happens, and the stigma and aspects of that is something that Rebecca's going to pick up shortly. And so that's just a very, very brief example of how all those features can be really become a vicious circle and become all interrelated. So one of the things that other people with MS say is that they might themselves perceive difficulties with their cognition. So they might be saying, my thinking isn't the same, I'm not able to concentrate. But then on some of the cognitive screening measures, that their performance is actually fine. So this discrepancy between self-reported cognitive difficulties and assessed cognition and how it's done was something that was coming up clinically a lot. And Laura Davenport, who you're going to hear from later in talking about her DClin research, looked at this, seeing if we could kind of explain some of that discrepancy. So looking at the discrepancy between self-reported cognitive difficulties and assessed cognition. And actually, again, unsurprisingly maybe, but looking at it from an evidence-based perspective with 177 people with MS, that self-reports of cognitive functioning was hugely influenced by depression and fatigue. And so really, it emphasises the importance of looking at cognition, but also not in isolation, looking at it in terms of mood and fatigue and many other factors. And we followed this up by another study by Clara Stein, who looked at another piece that explained some of it, which is estimated pre-MS abilities. And that also can make sense of another piece of the puzzle there, that it does explain some of the differences between self-reported cognition and assessed cognition. And so that makes sense in lots of ways, and actually Clara presented some of that research at the Belfast Ames Around Symposium a couple of years ago. And this became another interesting feature. So Clara actually went on and has now done a fantastic PhD looking at a follow-on area of this in terms of cognitive reserve in MS. So cognitive reserve, for people who might have researched older adults or in dementia areas, it refers, in general, cognitive reserve theory refers to an individual's ability to adapt cognitive processes in response to brain atrophy. So that might be normal aging or dementia-related brain atrophy. So cognitive reserve may protect against cognitive impairment in MS. But the thing is that a lot of the cognitive reserve measures were originally developed for a general older adult population and then older adult population with dementia. So we know that people with MS are a younger population when they're diagnosed, and the MS-specific related factors like depression, like from Laura's study and from the other studies, fatigue, disability, of course will impact the engagement with cognitive reserve enriching activities that build cognitive reserve after the diagnosis of MS. So those MS-related symptoms are likely to impact things like occupation, leisure activities, education. So this is Clara's systematic review that looked at 115 studies that looked at cognitive reserve in MS, and actually only about 31% of those studies had accounted for MS-specific related symptoms, like fatigue and depression and anxiety as potential confounding variables. So it's once you start looking at this in detail, it's really cognitive reserve in MS is an important area to look at. but it has to be MS specific in terms of the research. So actually one of Clara's follow-up PhD studies is presented in a poster out there today, how taking into account some of the MS symptoms can look at cognitive reserve of people with MS. So I suppose when we're thinking about psychosocial impact of MS, that there is the psychological, there's the neuropsychological, and there's also the social piece. So how your relationship with yourself and your relationship with others and your relationship in the world. One of the things that we, again, I suppose from a clinical perspective, one of the themes that was coming up with lots of people that I was working with was how they were feeling about themselves and how that was interrelated again with psychological well-being. So recently, a doctoral student, Derval McCormack, looked at this in a systematic review again, looking at body image and its relationship with psychological outcomes in MS. And looking at the 13 studies with about over 1,500 people with MS in total in them, we did show that there's preliminary evidence to suggest that negative body image is definitely associated with higher levels of psychological distress in MS, and conversely, that positive body image is associated with improved mood, self-esteem, better quality of life. So that's really good again, because it highlights that there is pathways for intervention and support. So the more that we can understand and make sense of what people with MS are experiencing, the better it can shape bespoke intervention programs. So this also was related to another study that Erin Brettany did for her master's, and this was looking at another topic that was coming up clinically, was thinking about the impact on sexual functioning for people with MS. So we know that sexual functioning difficulties is 5 times higher in people with MS compared to the general population. And, you know, it's always a bit random when we're saying it affects approximately 70% of women and 50 to 90% of men, but it's impacting people very much in their life. And we know that sexual functioning difficulties is a huge part of impacting people's quality of life. So Erin's master's research looked at 104 people with MS and 100 healthy controls to complete an online survey looking at some of these aspects of body image, sexual functioning, interoception, so the ability to monitor what's happening internally, mood and quality of life. And MS Ireland were super helpful in supporting this research, and there was a lot of the advertising and recruitment, so thank you very much for wherever Alison is. So what this study showed was that people with MS were significantly more impacted in sexual dysfunction and body image concerns compared to the healthy controls. And definitely that interrelationship again between psychological factors, body appreciation, body awareness, and mood variables predicted sexual dysfunction. So again, it's really important to think about what people with MS are saying is most impacting their quality of life, most impacting their life, and teasing apart the contributing variables, because there are some interventions that can support some of those aspects. Some of the evidence-based neuropsychological interventions, so cognitive rehabilitation, and Fiadhnait, who's going to be talking next, will touch on a little bit more of this, but there is a developing evidence base showing that cognitive rehabilitation in MS does show moderate effect sizes in attention, working memory and processing speed. We need more studies, we need more RCTs, which is, we're very lucky, I can't see Fiadhnait, wherever Fiadhnait is, that she's going to be talking about her RCT. And then from a psychological intervention perspective, there's a developing evidence base around cognitive behavioural therapy. People here have probably heard of that, CBT. And there's also developing evidence base about what we term third wave therapy. So that's things like acceptance commitment therapy, compassion-focused therapy, mindfulness-based interventions. And at last year's AIMS-RN conference, I presented on a pilot feasibility study that we had done about a neuropsychological intervention for managing these invisible symptoms of MS, which is since published. So that's 14 groups of people with MS, 118 participants. And the combination of it is psychoeducation, cognitive rehab, and then an ACT base, so this third wave therapy, looked really specifically to manage those invisible symptoms that can sometimes be neglected. We know from the qualitative feedback from participants that it was highly valued, and particularly from the focus groups, they identified that shared experience, a sense of community, feeling less alone, feeling less fearful, and gaining confidence and self-esteem, and learning how to communicate about the invisible symptoms that can sometimes go missed. So Some of these themes, again, think about the connections, and connections being a positive thing, and the peer support and community support that people with MS can really appreciate as well. And then also from an evaluation perspective, there was clinically and statistically significant reduction in both depression and anxiety symptoms, and an increased acceptance in MS following the group. Now, I think I talked about the acronym last year as well. I've since discovered NIMS is a neuroradiology software tool, so this is a terrible acronym. But anyway, the group itself is successful and has worked well. So in summary, I'm conscious that I'm really sort of giving a broad stroke overview of some of the neuropsychological and psychosocial studies that our research groups have been looking at over the last number of years, really impacted and influenced by what people with MS have been sharing with us as clinicians. And I suppose that bit around that interconnections, we really need that holistic understanding to make sense of and understand what's happening for people with MS. So I would very much advocate for that multi-domain assessment and also support to address both the visible and the invisible symptoms of MS. And really think about that interconnections. So interconnections of each of the domains, emotional, cognition, fatigue, pain, sleep, and so on, but also the interconnections socially. And that's been a really key part, and I know some of the other talks later on will pick that up too. So I suppose some of the future areas, my colleagues will talk about some of the other research projects that are following up, particularly longitudinal follow-up studies. But one of the areas that I'm interested in thinking about is social determinants of neurological conditions. So we know that people from minority backgrounds are going to be disproportionately affected by the symptoms of whatever condition they're living with. So that's something that I'm trying to think about how to shape that with MS research. And I am really delighted that Eva Scallon-Dowd is here today. She's going to be doing one of the flash talks later. She was our AIMS RN Summer Fellowship Scholar last summer. So she's going to be talking about the impact of MS on parenting. And I suppose following on from Eva's research, I'd really like to think about interventions and supports and resources for parents with MS. We'll have talked briefly about the neuropsychological interventions there, and Sinead will pick that up shortly. Our Summer Fellowship AIMS RN researcher this year, Hazima Hack, who's going to be starting next week, is actually looking at some of the features and what factors are associated with effective neuropsychological interventions in MS. And Sinead Hines and myself are co-supervising Hazima. So hopefully at next year's AIMS RN symposium, you might be able to hear the feedback from that. I have so many acknowledgements, really very much. You'll have heard really that so much of the themes of the research that I've been doing for a number of years have been very much driven from people with MS. And also, none of this research would be possible without the generosity of the people who take part. So thank you so much. So many clinicians and colleagues and collaborators, and I suppose today, AIMS RN in particular will feature because there's a couple of our research fellows who are going to be talking, and also MS Ireland for supporting a number of those studies that I mentioned earlier. Okay, thank you very much.